The following podcast is part of a certified educational activity featuring Professor Kaushik Ray from Imperial College London, Alan S. Brown, MD from Loyola Stritch School of Medicine, and Christy M. Ballantyne, MD, FACP, FACC from Baylor College of Medicine. Access the entire activity and complete the post-test at peerview.com/ZWU860. Downloadable slides and practice aids are also available.
Welcome to Mastering the Management of Hyperlipidemia in Statin-Treated or Statin-Intolerant patients. Recent treatment advances for patients that remain at high risk of ASCVD. My name's Kaushik Ray, and joining me today are Drs. Christy Ballantyne and Dr. Alan Brown. So what are we going to be covering today? Well, as with all of these type of events, we want to get an idea of clinical practice, and we're going to start with a case to really put things into context and discuss what best practice looks like. We will look at real-world data and unmet needs. We'll then move on to looking at the evolving horizon for hyperlipidemia management, current standards of care, but also future therapies, and a closer look at some of the newer non-statin lipid-lowering agents. And why do we do all of this? Well, we're practicing clinicians, and so we'd like to look at the practical considerations. And so what we'll do is finish off with a specific focus on how we apply all of the guidelines, the data, and how we apply them to targeting specific patients, including PCSK9 directed therapies. So it's my great pleasure to introduce my good friend and colleague, Christy Ballantyne, who's Professor of Medicine at Baylor College of Medicine, and he's going to be talking to us about the current perspectives on hyperlipidemia and ASCVD management. Christy.
Thank you, Coach. Well, I'd like to start off with a case to kind of mimic where we are in practice, some of these challenging patients that come up. This is a 59-year-old woman with hypercholesterolemia. It's been diagnosed for the last 10 years, but she's had difficulty with statins. She tried atorvastatin, simvastatin, pravastatin, fluvastatin, rosuvastatin, complained of myalgias with all of them. And she comes in, she says, I don't want to take any more statins. She's also got difficult to treat hypertension. Unfortunately, she still smokes 1 pack a day. And there's no family history of premature heart disease, but on physical examination, you notice that she has absent pedal pulses. She doesn't exercise much, but when you get a little further history, she says she does get some pain when she walks. So she's currently she's on 3 medicines for hypertension. She's on lisinopril, chlorthalidone, amlodipine. As you know, we commonly have to use combination therapy to control blood pressure. She's taking aspirin, she's taking CoQ10 because of these history of myalgias, and her lipid profile shows that her total cholesterol is 280, HDL 40, triglycerides 200. Her LDL cholesterol is 190. So we start off, first of all, what is her optimal LDL? Where would we like to have this patient? And how do we come up with these numbers? Well, we started off with epidemiology, and it was a very clear story. I'm involved with the ERIC study. We run the core laboratory, but the lower the LDL, the better in primary prevention. Basically, if we see LDLs less than 100, we have fewer events in individuals. The lowest quintile for women was 88. If we look at the progression of atherosclerosis, this is older data with statins, that the lower your LDL, the better the impact. You had less progression and more regression of atherosclerosis. And finally, if we look at the statin trials, we saw that the lower the LDL, the lower event rate. And in the final aspect of the statin trials, we compared high-intensity statins to lower-intensity statins, which got to lower levels of LDL cholesterol, and we saw that there was benefit. So it's a very consistent theme from epidemiology, studies looking at the progression of coronary atherosclerosis and regression, and also clinical events. Lower LDLs were better. So guidelines came out in the United States in 2018, and we'll talk about this. And we'll talk about the focus in terms of this statin data. They said that we have high-risk groups that clearly need statin therapy. One of them is an LDL greater than or equal to 190. These individuals, you don't have to calculate risk. They need high-intensity statin. Diabetes, we know that's an important group. And the other one for primary prevention is we use a risk calculator, the pooled cohort equation. Now, it's fundamental for everybody that we focus on a heart-healthy lifestyle. And this is a critical issue. This woman smokes. We've got to discuss smoking cessation. Even if she's been told on every visit, we need to keep going over this with our patients. You never know when someone's going to accept that challenge and stop smoking. We want to talk about diet, exercise. Triglycerides were up here. Those are usually very sensitive to lifestyle modification. You may have to work on her exercise program. What can she do if she can't walk a lot with this? And that might need more further evaluation. But we start off with lifestyle therapy for individuals. And as I mentioned, very important when we see disorders of triglycerides and glucose. In regards to statin therapy, we should be trying in a patient like this high-intensity statins. And what are those two? Those are atorvastatin and rosuvastatin. Atorvastatin at 40 to 80 milligrams, rosuvastatin 20 to 40 milligrams. She has tried high-intensity statins, says she has myalgias. She's also appropriately tried moderate-intensity statins and was not able to take those also. So this is a difficult issue that she's been through this. Now, one of the other things that's a major new aspect of our prevention guidelines is a kind of an emerging concept of secondary prevention. You know, we talk about risk assessment, and I told you some simple categories for who needs a statin therapy. For secondary prevention, we now talk about very high risk secondary prevention or atherosclerotic cardiovascular disease that's not at such a high risk. There's still a high risk, but we have very high risk and high risk. And why is that? It's because when you get into the greater the risk of the individual for an event, the more aggressive we need to be in terms of optimizing LDL reductions, getting to lower levels of LDL cholesterol, and there's concept of a threshold. If you have, in a very high risk patient, if you haven't gotten to an LDL of, if it's still over 70, they have too many atherogenic particles. LDL cholesterol is the surrogate that we usually measure to assess our atherogenic particles. You can measure ApoB or LDL particle concentration, but LDL cholesterol and non-HDL cholesterol are the most commonly used measures. If the LDL cholesterol is over 70 or the non-HDL is over 100, we need to consider non-statin therapy. And these guidelines came out because of a lot of evidence. I'm going to really kind of focus on statins. You'll hear more about non-statins, but the guidelines changed because of this increasingly large amount of evidence of how critical it is to get to low levels of LDL cholesterol. The greater the risk, the lower the level needed. So a very high-risk patient, who is that? Well, some of this I think we're, even without memorizing the list, intuitively, if someone's had a recent event, well, yeah, that's high risk. If you've had multiple MIs, that's a high-risk individual. Ischemic stroke, symptomatic peripheral arterial disease, which it appears from physical examination this lady has. That's a very high-risk group. And then we look at it is that if you have one of these factors, and do you have other high-risk conditions? Well, what are those? Well, one of them is persistently high LDL, which she has. She's got hypertension. She's a smoker. We don't have the eGFR here, but you sure better check that in somebody who's got peripheral arterial disease and severe hypertension. So this individual's not just primary prevention. From our examination, she falls into a very high-risk ASCVD category. Now, the European guidelines came out a year later, and this is some tension between guidelines. It's the same trial data. They have taken but the issue is a philosophical one. Here is one slide that kind of captures everything. The higher the risk of the individual, then the lower the level of LDL that you're trying to get to in that patient. And in this case, the very high risk group, rather than a threshold of 70 where you add something else, they use a target of 55. In practicality, it works out very similar. For example, this patient needs to get a lower LDL by whatever guideline you're looking at. Now let's talk a little bit more. Is this a rare case? Is it unusual to see someone who has a high LDL who's not on a statin therapy? So my colleague Salim Barani looked at this in the Pinnacle Registry, and this was a very large registry in the United States. There were almost 50,000 people who had LDLs 190 or higher. And statin use was only in 58%. So this is not unusual. 40% of the people were not on a statin who had out of this 50,000. So that's 20,000 people in these practices. Not a rare thing. Now, what's interesting is, so maybe, they weren't using high intensity. Presumably a lot of them had statin intolerance. But here's the part that to me was very surprising. Ezetimibe usage, 8.5%. PCSK9 inhibitor usage, 1.5%. Combination therapy, very low percentages here. This looks at the heterogeneity of usage, in which you can see it's all over the map. Now, most people were using statins, but when you look at these, the MRR for high-intensity statin use, or using ezetimibe or PCSK9, any non-statin, it's tremendously variable. So this is where we don't see consistent quality. We see most people using statins, but we don't see most people using high-intensity statins, and there's not much combination therapy usage. Well, is this registry unique? No, it's not. I'm also a part of the Gould registry, and we looked at people who've had an MI within the last year. High-intensity statin, 62% overall. Ezetimibe, 8.5%. PCSK9 inhibitor, 3.1%. Registry in Sweden, and the Swedes do a tremendous job. Look at high-intensity statin. They had 87% on high-intensity statin. That's spectacular. But look at the combination therapies. Ezetimibe, 3%. PCSK9 inhibitor was virtually non-existent. So let's go back to our case here. Statin-associated side effects, and that's maybe a better label than saying statin intolerance. We use them interchangeably, but in fact, most people who have statin-associated side effects are able to tolerate another statin at a lower dose, or sometimes we may get into some alternative dose. For example, Monday, Wednesday, Friday, a very low dose of a statin. I have many patients who can tolerate this, but have not been able to tolerate a usual starting dose of a statin given every day. What's the frequency of this problem? Well, it depends. If you are looking at a randomized clinical trial, now those people tend to be super motivated, and sometimes there's run-in phases where you have to tolerate the therapy. Clinical practice, you may see 5 to 20%. The other concerns patients have is about getting diabetes, transaminases. This is easy to follow up. Hepatic failure is extraordinarily rare, and memory and cognition, it's not only rare, it's not really clear if this is related to statins. So it's very important we reassure our patients and we work through evaluating secondary causes, hypothyroidism. You'll hear more about this because it's so important. What is the impact of adherence? Well, basically, if you don't take your medicines, you don't get the benefit and you have more events. And this is data showing increased MIs. If we take a look at the long-term persistence with statin therapy, the people who can take their medications long-term do much better than those who don't. So to me, the biggest problem we have in prevention is adherence. It's adherence to lifestyle, it's adherence to medications. This is the biggest challenge that we have with it. So, it's interesting. If we look at the Gould registry, we see very little usage of combination therapy for lipids, but 70% of people were hypertension. And physicians get it. If I'm not getting there with one therapy, maybe I can use a couple of different agents. With blood pressure, we go right off the bat, 2 drugs at a lower dose. more efficacy, fewer side effects. So the evidence and new guidelines have advanced much faster than the practice patterns. We see this in our most recent registry and real-world data. High-risk patients are frequently not on high-intensity statin therapy, and they frequently have persistent elevations of LDL cholesterol. There is increased evidence of non-statin therapy to lower LDL cholesterol further. This has led to changes in major guidelines, but at this time, if we go outside of lipid clinics, where it's very common, and with some of the practices that are really much more focused on lipids and cardiology practices, endocrinology, primary care, you have some of them, but the majority of people use very little combination therapy for lipids, despite the same practice doing this extensively for hypertension and for diabetes, two other chronic risk factors. Well, at this time, I'm going to turn it back to Coach to take us into some of the evolving horizon on hyperlipidemia management and a closer look at the newer non-statin lipid-lowering therapies. Coach?
Christy, thanks very much. That was, I think, a great introduction to the guidelines and actually really using the cases to highlight actually the challenges that we face and then those huge gaps that you see with the real-world data in multiple regions of the world. So, as Christy said, I'm going to be covering now new horizons, new therapies, and I'm going to start again with some real-world data that we published earlier on this year, almost identical to what you've seen from the Pinnacle and the Gould registry. And we'll start by looking at those individuals at highest risk, so those people with established cardiovascular disease. And I think that the take-home message is that we in Europe, in 18 countries in this study, have really been focusing on statin-only monotherapy. Roughly 84% of lipid-lowering treatment for people with ASCVD is in the form of monotherapy. Roughly half is with high-intensity statins. But just as you've seen, the use of ezetimibe in combination with a statin is about 9%. The use of PCSK9 inhibitors with an additional oral lipid-lowering agent is only about 1%. So what does that result in? Well, if we use the older guidelines where we were aiming for 70 for this patient population, then we would be getting roughly about half of our patients to goal with a statin, with a high-intensity statin, or with a statin and ezetimibe. We'd get more with a PCSK9 combination. But as soon as that goal shifts and we're now aiming for 55, then we're getting roughly about 1 in 5 to goal. So it's telling you that if you've shifted that goal and you are in general going to be aiming for lower targets, then we are going to need more combination therapy, and that's very clear. And then if you look in other regions of the world, so we've covered North America, we've covered Europe. If you look at Asia, and you can look at things like the Cephesus registry, you can look at DICES, and again, you can see the same thing, that as soon as you start to look at lower LDL targets or thresholds or goals, if you will, the number of, or the proportion of individuals getting to those targets really gets lower. And it doesn't matter which region of the world you're dealing with. And if you're dealing with people with established cardiovascular disease, that in itself is not a good thing. So one area that's really changed how we might be able to reach these targets is this discovery of this protein PCSK9. And using data from population-based studies, investigators have observed that those individuals who essentially had genetic sequences that loss of function that correlated with low levels of PCSK9 in the circulation, then these were individuals that had lower levels of LDL cholesterol. And because you can effectively mimic with a genetic study what we do with drugs, what was observed is that those individuals that had these gene variants throughout their life and correspondingly lower LDL cholesterol levels throughout their life from birth, they had a much lower risk of cardiovascular disease than you would expect. So that then begs the question, if we actually try to develop therapies, we might be able to lower cholesterol further, targeting PCSK9. So one of the important concepts, why do we think about add-on therapies? And I'll briefly go over this concept of relative and absolute risk. So for example, if you were to look at absolute and relative risk differences, and you look at people with similar 10-year risk, but very different levels of LDL cholesterol, if you start, for example, somebody with an LDL of 100, you're going to get a very large reduction in LDL cholesterol. And because that absolute difference in LDL translates into a larger relative risk reduction, starting with that very high baseline LDL gives you a bigger absolute benefit, if you will, and a smaller number need to treat. Now, when you start with a lower level of LDL cholesterol, then bringing LDL down further will have a smaller relative risk reduction and consequently a smaller absolute benefit. Now, if you basically go to the right-hand side and you compare absolute and relative risks now in people with different baseline risk, but similar baseline LDL, then basically a statin or a PCSK9 inhibitor at different starting levels are going to give you different absolute benefits. If you start with high risk, you get more benefit. If you start with high LDL, you get more benefit. So that's the simple take-home message, if you will, for those patients at very high risk. So here is a study which in some ways, and you've heard very nicely from Christy, that I think a lot of people underestimate the impact, and that's the Improve It study. By design, it was testing a hypothesis that if we treat people to below 70 milligrams per deciliter in the standard of care arm, as proven by Prove It, and we bring LDL down further, then does that translate into a difference in clinical events? Now, if you try to achieve that difference with ezetimibe, because you get a 20 to 25% further lowering of LDL cholesterol, the absolute difference, which is what's determining benefit, will be smaller. That's a function of design, although in clinical practice we tend to use ezetimibe in people with much higher LDL cholesterol levels. So the study did exactly what it was meant to do. So if you achieve a difference in LDL cholesterol of about 15 milligrams per deciliter, and you maintain that over a period of about 6 to 7 years, you'll get about a 6% relative risk reduction, and with the event rate in this particular study population, about a 2% absolute benefit. So that's really important. And if we start to look at, for example, real world data and real world cohorts, so we might want to go back and forth and say, okay, how many patients might actually achieve these goals? So the Improve It data took people with slightly lower LDL cholesterol levels, but in the real world, cholesterol levels tend to be a lot higher. So if we, for example, look at this real world data and looking at populations that would meet the Fourier criteria, then you can estimate how many people might achieve an LDL below 70, for example, if you optimize statin therapy, because we know that's not always done. And if we add in ezetimibe, because you start with a higher LDL, it will get many of these people to goal. So if you did that, then basically about 18%, so 1 in 5 people in this cohort meeting the Fourier criteria could actually get to goal in theory if you optimize statins. If you added in ezetimibe, you'd get about 50% to goal, and you could get about 2/3 to goal through both optimization of both statins and ezetimibe. So let's go back and think about PCSK9. So the first thing you've got to realize is that we don't necessarily need PCSK9 inhibitors for absolutely everybody, and that's really what some of these data I've just shown you really reinforce. But there are some people that may get insufficient reduction because they start at very high levels of LDL, or because they can't tolerate statins. We've already talked about the importance of combination therapy. So how do PCSK9 inhibitors, the monoclonals, work? So what this slide shows you is that if I inject into a person a monoclonal antibody, in this case evolocumab, blood levels of the drug go up after a single shot, and they gradually wane and they fall away and go back towards baseline. Now, because this is binding PCSK9 in the circulation, everything that's in blood effectively drops. The amount of free PCSK9 drops, and gradually you get, as the drug levels fall, the amount of PCSK9 in the free PCSK9 in the circulation goes back up. But there is a lag phase in LDL reduction. So LDL fall lags behind PCSK9, and even though PCSK9 levels go back up, you don't see an immediate rise in LDL cholesterol. And that gives you some ideas in terms of how you might want to target dosing regimens. So if you use 20 milligrams of evolocumab, you'll get a reduction in PCSK9, but you get a rapid bounce back up. So on the right, you see a small reduction in LDL, and you get this seesaw. With more of a dose, so 70 milligrams, you see more reduction and a longer duration of effect. And that's shown in the middle graph on the right. And then if I double the dose to 140 every 2 weeks, what we are now seeing is not more reduction, but a sustained reduction in LDL cholesterol with less peak and troughs. So, does this translate into a reduction in clinical events? And so what you can see here is data from the Fourier trial, which enrolled over 27,000 patients with stable cardiovascular disease and with LDLs above 70, despite maximally tolerated statins, and looked at this composite of endpoints. And overall, for this 3-point MACE endpoint, the relative benefit was about 20%. Now, a lot of people turn around and say, well, but this drug lowers LDL by 60%. Why the modest benefit? It's actually not modest benefit, because remember, the average follow-up is about 2.2 years. And we know that in the first year of treatment with statins or with a monoclonal, you get about half the benefit that's observed in later years. And that's exactly what you see. So in year 1, with this endpoint, you've got about a 19% benefit, but in year 2 onwards, you're getting larger reductions, about 1/3. So that composite of 20% is somewhere in between. Now, we've now got evidence from a second PCSK9 inhibitor trial. This studied a patient population soon after an ACS event, and again had an LDL gatekeeper. So your LDL, despite more than 90% use of high-intensity statins, had to be above 70. At this time, the drug was alirocumab. Slightly different study design in that if LDL cholesterol, starting with a level of 75 milligrams, the dose could be increased to achieve, if you like, a treat to target goal of somewhere between 30 and 55. If you didn't achieve that, you up-titrated the dose of the drug. If you fell too low on 2 subsequent visits, and that's not because we ourselves necessarily have a concern, but at the time that the study was started, the investigators felt that it wanted to be prudent. So they had a back titration option. So many of the patients in the alirocumab ITT, the randomized group, actually were back titrated, and maybe compared to a treat-all approach, if you will, got slightly less reduction. So that is one of the things that might make the results seem a little bit less impressive than you might think. But the study did exactly what it was supposed to, i.e. it showed that there was a 15% reduction. This is what it was powered for, showed a 15% reduction in the composite endpoint for that particular trial, which was a 4-point composite. So those are great. So is that it? Is that the be-all and the end-all? Well, we know that there are patients who may not like the idea of an injectable. And there are also cost restrictions as well with some of these therapies. So we're actually quite fortunate that in the last year, the first oral lipid lowering agent, bempedoic acid, has been approved in both Europe and in North America. And this was one of the larger studies. This was Clear Wisdom. And this was in a patient population where they had maximally tolerated statins. Now, this is a drug that works in the same pathway as statins. And so you get about an additional 18% reduction in LDL cholesterol compared to placebo. And if you look at the population in other trials of bempedoic acid, where perhaps background statin therapy is either low or non-existent because the patient is truly statin intolerant, because you're working through the same pathway and you don't have any background statin on board, the LDL reduction is somewhat greater and of the order of 25 to 28%. So that's a nice little nuance with this particular approach. So what additional agents do we have potentially in the future? So I talked earlier about PCSK9s, and one thing that is really exciting is that both PCSK9s and statins, and bempedoic acid for that matter, and also indirectly ezetimibe, work by increasing the expression of the LDL receptor. So high levels of PCSK9 are a bad thing in that they destroy the LDL receptor, meaning it doesn't matter what you've got, they are basically being turned over much more quickly, so you have fewer of those and therefore blood levels are higher. So current approaches to lowering blood levels focus on using a monoclonal binding what's in the circulation. So if you will, that's a bit like holding holding a bucket under the liver, filling it with PCSK9 and replacing that every 2 weeks when it gets full. An alternative is to switch off the production of PCSK9 in the liver, because 70% of what you see in blood comes from the liver. So we can do that with so-called RNA silencing-based approaches. And there are two types that are in development for a number of lipid targets. And I've basically tried to separate them here. One is called antisense, and it uses a single strand of RNA, and it works within the nucleus. The other uses a slightly different approach that I'll elaborate on, called small interferent RNA. This is a double strand of RNA that's again an injectable, and this works in the cytoplasm. So one of the big challenges that we have with many of these agents, where you want to achieve uptake in the liver and that limited early development, is the volume of drug that you have to administer. And that might lead to potential, for example, allergic reactions, so rashes, for example, at the injection site. One major development has been the discovery that the liver expresses something called GalNAc, or something called the acyl-glycoprotein receptor. And what this does is recognize a sugar moiety called GalNAc. So when your cells age, they express this sugar moiety called GalNAc. And this internalizes those cells so they can be removed. So by identifying that, we can tag an artificial molecule with GalNAc. So within 4 hours of an injection, all of this is taken up by the liver. So there's nothing measurable in blood, which means you can reduce the injection volume, the injection dose, reducing potential injection site adverse events and rashes, for example. So this basically has enabled us to deliver these small interfering RNAs at a low dose, which are then taken up by the liver. Now, what do they do within the liver? Well, the second thing that has been really a huge milestone has been the development of this whole process called RNA interference and the RNA-induced silencing complex. So what is it? Well, basically, within every cell in your body, there is this complex called RISC that is binding segments of RNA that essentially tell it which genes to switch off. So your body is already doing this all the time. We can artificially give it a target, for example, PCSK9. And basically your artificial or pharmacologically modified RNA segment, by binding to this RISC complex, can then target multiple messenger RNA transcripts and break them down. So this is a really efficient way of stopping the message from the protein, from the gene rather, getting to the protein. And that's how you reduce blood levels of PCSK9. So we tested that in a couple of studies, and I'm going to show you a few of those. So this was the dose-finding Orion 1 trial. And you can see with 3 different doses of a single injection of a drug called inclisiran, which is an investigational drug at the moment. This basically, a single dose on top of statins could give you a significant reduction in LDL cholesterol. Now, it doesn't make sense to look at an individual time point because of this long duration of effect. And in fact, what you're interested in is the area under the curve. So a single dose of 300 milligrams, for example, gives you 9-month coverage for a 41% lowering. Now, if we give an individual a second dose at day 90, we don't really get much more reduction, but what we get is a longer duration of effect. So after that second dose, what you get is over a 9-month cycle is an average reduction of about 50%. And if you look at visually at this graph, between day 90 and day 270, so roughly 6 months apart, that gap basically means that if we were to inject now somebody at month 9, so 6 months after the second injection, we might be able to go to a twice-a-year dosing schedule, but still maintain a 50% reduction. A busy slide, but what I'm going to just show you on this, if you look at the bottom right-hand corner, these are waterfall plots of time telling you if I've given somebody 2 injections of inclisiran 300 milligrams at day 1 and day 90, how long do they continue to respond and get at least a 20% reduction in LDL compared to baseline. Because of that mechanism of action I showed you, virtually everybody is still getting at least a 20% reduction almost through to 1 year. And that basically is highlighted on this time course, if you like, and we stopped the study at 1 year. This was the dose-finding study, and you can see with the 2-dose regimen on the right that basically from the peak reduction, LDL cholesterol does return to baseline, but it does so at a rate of about 2 to 4% per month. So even if you miss, for example, a visit, your LDL isn't really going to go back to normal because of this long duration of action. So this actually allows us to think in a totally different way. We can start to think about population health. We can start to think about coverage. On the left-hand side, in the middle, with a single shot of inclisiran 300, you can get an annual coverage, if you will, of about 36% LDL lowering. With 2 shots on the right-hand side and nothing else, 1 and 3 months later, if you follow people up for a year, your annual coverage is just under 50%. I said to you that the aim was to try and go for a dosing interval and a dosing regimen whereby we could maintain a 50% reduction in LDL. So we tested that in 2 parallel studies called Orion 10 and 11 that were published this year. And basically the dosing interval was day 1, day 90, and then 6 months thereafter, and following people up for 18 months. On the left-hand side, you can see that even with this infrequent dosing interval, because of this highly effective and efficient mechanism of drug delivery and action, if you will, you can maintain lockdown of PCSK9, so you don't need an injection frequency more frequent than was used in this study. And what that basically does is it gives you, on average in these 2 trials, if you put them together, about a 50% reduction in LDL cholesterol. Safety is obviously as important as efficacy, and if you look at the 2 trial data side by side, this is obviously not powered for cardiovascular outcomes, that is ongoing, but you can see that certainly no harm and a favorable trend in the right direction that needs confirmation. If you look at major adverse events that one might expect, you see basically a small excess of injection site reactions, but these are mild, these are transient, none are persistent and none are severe. Because the drug works in the liver and has a long duration of action, you might be interested in liver safety. Now here, this is virtually identical in each of these trials. When you look at CK, muscle safety, when you look at other hematological parameters, again, nothing. So what might this help us with? So we talk a lot about adherence, and you heard that earlier on, and that may be something that really can be afforded by this therapy, because our individual patients, so this is data from Orion 1, allegedly taking a stable dose of statin by protocol. But all we've done is measured the same individual. These are individual patients shown in the bars. 6 months later, some go up, some go down by as much as 40%. That's not biological variability. They were all supposedly on a stable dose. That is the effect of adherence or non-adherence at different time points. Now, that is happening on the right-hand side. But because of this efficient mechanism of action and the fact that this was physician administered in that trial setting, you basically get additional reductions even if there is an element of non-adherence happening in the backgrounds to your daily oral regimen. Why is that important? Well, long-term variability counts. It matters. The more variable your LDL, like blood pressure, like HbA1c, the worse your cardiovascular outcomes. We see that in people taking statin therapy, this is Jupiter, that there's a group of individuals will get less than the average percentage reduction. Some may go up. Why is that? It's probably going to be adherence. So that is an unmet need. So certainly in the future, what we might be able to do is tackle this issue. This is another example of real-world data, so electronic health records from 3 million individuals. And what you can see is that two things determine your blood levels: what a doctor prescribes, and the more powerful the statin regimen, of course, the bigger the reduction, but the patient has to take it. So you get the best results when the doctor prescribes the right treatment, the higher intensity regimens, and the patient takes them. And that tracks absolutely with risk. And at the moment, instead of at the bottom, with the grey bars, ideal, optimal adherence, optimal statin intensity, we're seeing this push up in events, and that is because of suboptimal prescribing and suboptimal adherence. So what we might actually be able to do in the future, because risk really doesn't matter, or if you like, nature, risk, doesn't care how you lower LDL. You can do it with 365 pills a year, 26 injections a year, 2 injections a year, and in the future, maybe even less frequent therapies. All that's going to change is adherence. And because you improve adherence, you will change the average long-term reduction in LDL cholesterol. Now, if you project that over a 5-year period, maybe you don't see much of a difference. But over a 52-year period, for example, looking at the genetics, that will translate into large reductions in cardiovascular events and improved population health. So statins, of course, are first line. They're very effective when taken properly. We need to optimize the dose to the maximum tolerated doses. Currently, for PCSK9, the approved indication or the approved therapies are the monoclonals, which need to be taken every 2 weeks to 1 month, depending upon the dose. In the future, we may well get additional therapies. We know that the therapies currently that lower circulating PCSK9 that are approved, the MABs, also reduce cardiovascular events. Now, there are some important classes of therapies emerging. Some are oral agents working through the same pathway as statins. Others are really offering us a unique approach, which is this infrequent dosing interval through RNA interference. So 2 studies that I showed you, large studies of over 3,000 individuals, essentially give us this new concept, which is this concept of annualized coverage, when we might be able to further reduce LDL by 50% with 2 injections a year. The drug is not approved, of course, yet. It appears to be safe, but overall, the only difference that was observed is a small excess of injection site adverse events. So I hope you enjoyed that as a look into the future, but I want to bring you back to really the practical challenges and the patient. And there's no one better than to do that than Alan Brown. He's going to talk about practical considerations, a special focus on the role and clinical applications of PCSK9 targeted agents. He's the director at the Division of Cardiology in Chicago. And Alan, welcome.
Well, thank you very much, Professor Ray. That was a fantastic review of the science and the newer agents, as well as an introduction to population health, which I think is a very interesting topic. And of course, Christy went through the guidelines and set an outstanding basis for how to think about an approach to patients. And I'm going to spend my time sort of summarizing with a case, trying to take pieces of what's already been presented and make you think about how you would apply those things in practice. So let's think about this patient coming to your office. She's 59 years old. She has a long history of hypercholesterolemia. She had intolerance to multiple statins due to myalgia. So muscle aches on atorvastatin, Simva, Prava, Fluva, and rosuvastatin. So she's already tried a lot of different statins. She says, I'm not taking statins again. I don't care, whether you have something new, I'm not going to take a statin. She has a history of poorly controlled hypertension. She still smokes, no family history, but she has no pulses in the feet, so she has peripheral arterial disease clinically. So based on what you heard from Dr. Ballantyne, this patient certainly fulfills a very high-risk patient in the sense that she has established atherosclerosis as well as multiple other risk factors. The medicines she's currently on are her antihypertensives, as you can see, lisinopril and chlorthalidone and amlodipine. She's on aspirin. She's taking CoQ10. Somebody told her that would help her with the muscle aches, but it didn't work in her, and the data for coenzyme Q10 really relieving muscle aches is not very robust, though some patients swear by it, and if they feel better on it, I'd certainly tell them continue it. Now look at her lipid profile. Remember, this is a smoking 59-year-old female with hypertension and on no statin therapy. Her LDL is 190. So extremely high-risk patient, especially when you add in that she has peripheral arterial disease. And so the question is, what to do next. So just a brief review of what's already been discussed. Myalgia is relatively common, actually, less so in studies and clinical trials. They say somewhere between 1 and 5%. But we know from patients looking at registries and also questionnaires that sometimes as many as a third of patients will complain of muscle aches on statins. There's no doubt that certain things can predispose patients for myopathy, and that would include things like hypothyroidism that is not adequately treated. But for reasons unclear, and probably in some patients due to genetic SNPs and in others supratentorial issues, a fair number of patients have muscle aches. So this is fairly common with a normal CPK. Now, what is rare is myositis, which would be elevated CPK with diffuse muscle pain and weakness. That's extremely rare. Rhabdomyolysis is even more rare. And then there's a very rare syndrome called statin-associated autoimmune myopathy, where patients have an antibody to HMG-CR, which is the HMG-CoA reductase protein. So this patient can't tolerate anything, and we all face this. I'd be shocked if we didn't all see this in our office probably several times a month. And so what are your options? Well, you can change to a different statin, and Dr. Ballantyne already pointed out that that's one of the strategies. And over the years, before we had alternate therapies other than statins, that was our option. And we would go through 6, 7 different statins, including older statins that were generic and maybe not being marketed as much anymore. Or we would try to switch to once or twice a week of the longer acting statins like atorvastatin or rosuvastatin. That's still a very reasonable strategy, especially with the data that we have about the safety of statins as well as the efficacy in reducing cardiovascular events. If you're going to use twice weekly therapy, you should use statins that have a little bit longer half-life. And what's worked particularly well and has some data, as I mentioned, is atorvastatin and rosuvastatin. Now, obviously, we have non-statins now, and we'd like to stick with the ones that that have clinical evidence. Niacin looks like it does more harm than good, but we do have older studies suggesting that adding a bile acid sequestrant will give you a reduction in LDL of 17 to 20%, very similar to ezetimibe. You can use ezetimibe plus a bile acid resin, and of course now we have the PCSK9 targeting therapies such as evolocumab and alirocumab available, which give you not only close to a 60% LDL reduction, but a reduction in cardiovascular events. And for those patients on the border who are lower risk, water-soluble fiber as well as plant stanols can reduce LDL modestly at the most. You can get 7 to 10% reduction in LDL. So obviously, when patients are having statin myopathy, you want to rule out hypothyroidism. You want to make sure that they're not taking other medications that might aggravate the myopathy. There is a dose relationship with statin side effects, so cutting the statin out until the patient's symptoms are completely gone and then reintroducing the statin is actually effective in some patients. And you would reintroduce it at a lower dose and see how they do for a while, and then could add a non-statin or gradually increase the dose. There was some observational studies suggesting that people with low vitamin D who had myopathy got an improvement when you added vitamin D. Those were not randomized controlled trials, and I'm not sure that you could consistently expect vitamin D replacement to help myopathy, but you could come up with a number of reasons to try and have a normal vitamin D. So if you made the decision to replace vitamin D, that's certainly reasonable. But I think the benefit in statin myopathy is probably overstated. And then, of course, you would be considering non-statin therapy. So if we get back to our patient, we clearly are going to be considering that. Now, PCSK9 inhibitor would be a top of mind, wouldn't it, in this patient with an LDL of 190 and peripheral arterial disease. And if you look at the Fourier data, what you find is people with peripheral arterial disease really got the greatest benefit in the trial in terms of reduction of cardiovascular events. So and this is a subgroup analysis from Fourier in patients with and without peripheral arterial disease, and you can see that you got an even greater reduction in risk of a cardiovascular event when giving evolocumab to a patient with peripheral arterial disease. So one would be quick to think of PCSK9 inhibitor in our patient. The other issue is that our LDL is 190. So thinking about something like bempedoic acid or ezetimibe, you're going to get 17 or 20% reduction. There's probably an additive effect. So if you used a combination of bempedoic acid and ezetimibe, you might get as much as a 38% LDL reduction. But that's still not going to get that 190 down below the threshold of 70 that you're shooting for. And in fact, you may want to use a PCSK9 inhibitor and consider bempedoic acid in this patient because you're going to want to get the LDL well below 70. So again, 59-year-old patient, hypercholesterolemia, but no palpable pulses in the feet. She's got atherosclerotic vascular disease. And I would challenge you to think how many times when you don't feel pulses in the feet or you hear a femoral bruit, does it dawn on you that this patient shouldn't leave my office without a statin? And I would say that probably you don't think about that as much as you should. We think about it in everybody who's had an angioplasty or bypass surgery or a coronary angiogram showing atherosclerosis and even an abnormal calcium score. But we're not thinking as much about peripheral arterial disease. And this might be the reason that they got so much benefit with treatment because there has been a delay in aggressiveness of therapy prior to their diagnosis. So I think you should keep in the back of your mind that peripheral arterial disease is a marker of a patient who's going to get really significant benefit, particularly from a PCSK9 inhibitor. Now, we talked about ruling out hypothyroidism. This is a patient whose LDL is 190. It's on the borderline for possible familial hypercholesterolemia. And though she doesn't have a family history of heart disease, that certainly doesn't rule out FH. Maybe her mother had it and she didn't smoke and got away with it without atherosclerosis. But I certainly would consider genetic testing at this level of LDL just to make sure she doesn't have familial hypercholesterolemia. And you might ask, well, why would you do that? Well, because if she carries the gene, her risk for atherosclerosis is much higher, 22 times the average risk. Whereas if she's gene negative, she'd still have high risk, six-fold increase in risk, but not nearly as high a risk as if she carried the gene. And the other thing is you'd want to screen her children in any case for lipid profiles to make sure that her children didn't inherit her dyslipidemia, knowing that if she had a mutation for familial hypercholesterolemia, there would be a 50-50 chance that her child might have inherited it. And we know that we treat those children starting at age 8 with statin therapy, and we don't want to wait until they develop atherosclerosis. Then we already discussed the possibility of ezetimibe, bempedoic acid, or bile acid resin that we could use in this patient, but looking at the percent reduction we need in LDL, a PCSK9 inhibitor makes sense, and the outcome data in people with peripheral arterial disease is so striking that that would be an excellent choice in this patient. All right, let's look at a different patient. Here's a 66-year-old male. He's got a long history of hypertension. He's had a prior MI, and now he comes in with unstable angina. He's got poorly controlled hypertension. He's like many of my patients. No one knew he was a drinker until they saw him sober once. And so we see here that he was moderate alcohol intake, smokes 2 packs a day. His blood pressure is uncontrolled, which is definitely often related to the alcohol. I'm sure many of you know that alcohol is a common cause of hypertension. And his LDL is still 120, and you can see he's on low-dose atorvastatin. And he's on his antihypertensives of just chlorthalidone and amlodipine, and appropriately on aspirin. So the first order of business is to take care of his unstable coronary syndrome, right? So, you know, as an interventionalist, this is a patient I would take to the cath lab. We have lots of data that intervening on a patient with unstable or acute coronary syndrome reduces event rates in the future. So he would undergo a cardiac cath, and we would deal with whatever we found in terms of the lesion. Now, he definitely falls into that very high-risk group that Dr. Ballantyne already talked about that would be appropriate for a PCSK9 inhibitor based on the guidelines. He's got a recent acute coronary syndrome, he has a prior MI, and he's over age 65 with hypertension and smoking. Let me just make a point, because this is very difficult to remember, right? And I'm a big believer that guidelines should fit in your shirt pocket. Once they start getting complicated, it's hard to remember them. So there's the 4 major ASCVD events, and to be classified as very high risk, you have to have more than one of those. So in this case, this patient has 2. Or if you only have 1 major ASCVD event, but you have more than one of the high-risk conditions below, that would also place you in the very high-risk category. And those would be that would be the category where a PCSK9 inhibitor would be appropriate based on the 2018 multi-organizational guidelines. So how do you remember that, right? Well, it is difficult, but let me just tell you that a review of a large database suggests that if you have any one of those 4 major ASCVD events, there's a 93% chance you're going to have multiple of the high-risk conditions below. So if you have either a recent acute coronary syndrome, an old infarction, prior stroke, or symptomatic peripheral arterial disease, it's very, very likely that you would be very high risk based on the guidelines. And you might ask, well, how did they come up with this for the guidelines? What they did is they used the enrollment criteria that were beautifully laid out by Professor Ray for the 2 PCSK9 trials. And these were the type of patients that they enrolled in those trials. So when they wrote the guidelines, they said, you know what, we're going to say that PCSK9 inhibitors are appropriate for the types of patients that were studied in the trials. And this was very close to the enrollment criteria for both of those outcome trials with both evolocumab and alirocumab. So when we look at the guidelines, again, for secondary prevention, this patient has clinical ASCVD. He falls in the very high risk group on the right side of the slide, as we've discussed. He would get high intensity statin, and so you would want to increase that atorvastatin from 10 milligrams to 80 milligrams. But keep in mind, every time you double the dose of a statin, you only get 5 to 6% additional LDL lowering. So by going from 10 to 20 to 40 to 80, you're still only going to get roughly an additional 20% LDL lowering, which is appropriate because the clinical trials showed outcome data with high-dose statins. But on the other hand, you know that you're still going to be above that threshold of 70. So this is a patient who you very likely are going to be adding a PCSK9 inhibitor. And we know that treating these patients aggressively and early will lead to better outcomes in the long run. And note that the guidelines say you should step through ezetimibe if the LDL remains above 70. That decision was made because ezetimibe was inexpensive, generic, and has outcome data, as we already heard from the IMPROVE-IT study. It turns out that there is data that you could go directly to a PCSK9 inhibitor, and you will likely need that, knowing how much LDL reduction you need in this patient, roughly about 60%. But that was thought to be less cost effective based on the data that was available at the time these guidelines were written. So this is the first set of clinical guidelines where there was a mandate to also look at cost effectiveness of therapy. Now, many of you know that the PCSK9 inhibitors came down in price by about 60% right around the time these guidelines were released, and that improved the cost effectiveness significantly for PCSK9 inhibitors. So certainly in a patient with the LDL over 100, such as this patient, it would be reasonable value to go directly to a PCSK9 inhibitor. The other reason the guideline group felt you should use ezetimibe before you jump to a PCSK9 inhibitor is because the response to ezetimibe, though on the average is 17 to 20% LDL lowering, is quite variable, and some patients get a much greater reduction in LDL on ezetimibe, and they felt it's inexpensive, generic, and it's worth a try to see where you end up. So what would we do for this patient? Well, obviously, I would use my fail-safe, proven way of getting the patient to quit smoking forever. I would sew his thumbs to his rear end. That works 100% of the time. But obviously, all kidding aside, we would try our best to get him off the cigarettes using medication if necessary and counseling, and also to reduce his alcohol intake. And I would remind him that that combination of alcohol and tobacco has unbelievably high risk for esophageal cancer, for which we have little options in terms of treatment. We would intervene on him urgently in the cath lab, as I mentioned, and so he's going to get aspirin and ticagrelor after his stent. We would up his atorvastatin to 80 milligrams, knowing that that's not going to be adequate, and then we would consider adding ezetimibe, and most likely would end up on a PCSK9 inhibitor, as we discussed. So here's a 57-year-old South Asian female with a history of hypertension, ischemic heart disease, and dyslipidemia. She had a recent acute coronary syndrome. She, turns out, didn't fill any of her prescriptions. She said she's on so many drugs, the drugs are expensive, and she's got too many drugs in her medicine cabinet. So before she came in with her acute coronary syndrome, she was supposed to be taking aspirin, lisinopril, atorvastatin, and furosemide. And at the time of her discharge, she was supposed to be on aspirin, lisinopril, furosemide, but of course her atorvastatin dose would have been maximized. She had PRN nitroglycerin, and because she had an acute coronary syndrome, she would be on antiplatelet therapy as well as atenolol. So this has already been discussed by Dr. Ballantyne and by Professor Ray that, at about a year, somewhere around half the patients are actually still on their therapy. So as excited as we get about the results of clinical trials, whatever the outcomes are on those trials, you could basically divide them in half by 1 year, because half the patients are not taking the drugs at 1 year. And we also know that as each passing month goes by, the number on high-dose statin starts to drop, so that by about 6 months, less than half of patients that were started on high-dose statin are still on them. And this is a real problem, as Professor Ray pointed out, with regard to the future of healthcare, which is population health. It turns out that we also have outcome data that shows that the people who don't take their statins, for example, have a much higher incidence of cardiovascular events. So non-adherence is more than just a pain in the neck for the clinician. It actually translates into significantly higher risk for the patient who's not taking their medication. So when we look at this Kaiser Permanente study, looking at 1,000 patients that had coronary disease and they were started on statins, they had about 50% or more were not taking their statins. It was obviously associated with a gradual increase in their LDL as they went off the statins, just as Professor Ray postulated in his presentation. And it unfortunately translated into a higher risk of cardiovascular events. So here's where you really sit down and say, well, let's talk about what the problem is. And the most important thing for adherence, to get patients to take the medicine, is to actually ask about it during the visit. And this is something we don't think about too often. But no patient should leave your office without you saying, are you taking your medicines? And if not, why not? And are there any issues that we can work through together? So understand what the patient's concerns are about the therapy. This is a very high-risk patient. Remember, South Asians have 3 to 4 times the risk of other populations for atherosclerotic cardiovascular disease, felt to be due to an increase in insulin resistance as well as a high prevalence of Lp(a). So here's a relatively young South Asian female already with heart disease, and it's very important she takes her therapies to reduce her risk of future events. Find out if the drugs are costing too much for her, and if so, what can we do to help her, whether it be samples or working with the pharmaceutical companies to offer lower cost drugs for the patient, and share those resources with her. Sometimes patients say, I have to take my drugs in the morning, and I'm busy in the morning and I always forget. And you can think of simple ways to help them, like why don't you just rubber band your pills to your toothpaste? What's something you do every morning like clockwork? That's where the pills need to be. And a similar approach before going to bed if that's when they're taking their medications. So just working through those things and taking just a couple minutes during the office visit to even ask about whether they're taking their medicines is actually the single biggest factor in improving compliance, and also discussing with them the importance of each of their therapies and why they're taking it. So population health is something that came up, and we've talked about now PCSK9 antibodies such as evolocumab and alirocumab. We've talked about bempedoic acid, which the mechanism was beautifully discussed in Professor Ray's talk, and we know that the efficacy is 17 to 20% by itself and maybe 38% when added to ezetimibe. But what about the future of healthcare? Because we're going to have to think about this. So I wear a second hat as a co-director of a service line for a large healthcare system. And I will tell you that what we see in the future is a movement away from getting paid for the procedures we do, and a movement towards getting paid for better outcomes for our patients. It's all going to boil down to, does the patient get better? And we're seeing that already with CMS, that you're getting paid sort of a bulk rate for taking care of certain diseases, and it doesn't matter whether the patient gets readmitted to the hospital or has a complication, has to stay longer. What you get paid for is that particular disease state. Now, why am I harping on this? Professor Ray already alluded to this. Think about a therapy like inclisiran, which we've discussed, that would be given by a healthcare professional. It could be given by any provider in healthcare. Could be a pharmacist, could be a nurse practitioner, or a physician. But the patient will get it only every 6 months. Now, we know that 50% of people are off of their traditional therapies that they're taking at home by about 1 year. So imagine what the outcomes could look like if you knew the patient was getting their therapy because you gave it to them. Now, we could argue that maybe 10% of people won't show up to the clinic, so we're not going to have 100% adherence. But if we had 90% adherence, think of how many additional events we would save. So I'm going to finish up with my key take-home messages for patients. So in patients with statin intolerance, it's certainly reasonable to try all statins. We have so much data for so many years on statins. So don't just give up if they have a side effect to one statin. They're not allergic to the statin. Adherence remains a problem. And again, the most important approach is to ask about it. That sounds silly, but it's really very, very important. You need to attend to it because if you ask the patient about it, they understand that it's important. And you'll often discover that there are barriers that you can work through with the patients to help reduce the chance of them not taking their medications. Very high-risk patients require aggressive therapy if the LDL remains above that threshold of 70. Ideally, we want to use things that have been proven to have benefit in terms of outcomes in clinical trials. And the earlier you treat, the better the long-term benefit. Remember that lipid therapy is like a 401k plan. The longer the patient's on it, the lower the risk. So you want to start early and continue investing on a regular basis. And these newer therapies, such as inclisiran, that can be given at longer dose intervals, may hold the key to improved adherence in the future and give us more global strategies as healthcare systems for management of these large populations. So thank you very much for your attention.
That's great. Thank you, Alan. So, I mean, maybe it's worth actually just spending a little bit of time just talking about some of these cases. You know, your first patient, for example, the high LDL cholesterol, 190, you talked about looking for familial hypercholesterolemia. What about also lipoprotein(a) elevations? You know, peripheral arterial disease, LDL that is really quite high. It's probably a little bit more common than FH. It may be that Lp(a) was the Cinderella and not really thought about so much. What do you think? Would you recommend doing that? And would that, if it was elevated, would that change your decision?
So that's a very good question. Especially if this patient had tried statins and had a poor response to them, that would be a signal that it could be Lp(a). I think I could make a case for doing Lp(a) in virtually everybody. That's a controversial discussion right now. Now, what would you do if it's elevated? Well, we know that we have at least some data that lowering LDL more aggressively in people with high Lp(a) attenuates the risk. We don't have any outcome data yet about lowering Lp(a) because we haven't had a drug that consistently lowers it, though the PCSK9 inhibitors can lower it about 30% in some individuals. Now, that's on average, you see that reduction in Lp(a), but it isn't actually predictable in individuals. Some individuals actually have the Lp(a) go up even though their LDL comes down a lot. But some statistical analyses suggest that in patients who get the LDL reduction from the PCSK9 inhibitor, but who also get a reduction in Lp(a), that there may be an improvement in outcomes. And of course, now that we have new therapies on the horizon that can lower Lp(a) significantly, we will be able to test the hypothesis that it should be a goal of treatment. So very interesting. I think if it's elevated in this patient, I would be extremely aggressive, try to get that LDL level as low as possible. And that would be another reason that I would choose a PCSK9 inhibitor early. And I would do a follow-up Lp(a) just to see if their Lp(a) came down.
And it's the million-dollar question, isn't it? Risk assessment. I mean, we go on all of these things and there's a precision around that and you're thinking about an average. And the more things that you have that push your absolute risk up, the more benefit you're going to get. But I wanted to bring something in. I mean, so I think we all agree we'd go with a PCSK9 inhibitor in that first patient. But the patient was intolerant of multiple statins. And I know, for example, there's sort of data that I've looked at in European registries of real-world use of evolocumab. Now, because of reimbursement levels, that LDL threshold for many people is one of statin intolerance, and so there's no statin in the background. Yet, if you look at patients who are on either a statin or ezetimibe, when added, or a PCSK9 inhibitor is added, the average LDL, is by definition lower. So in this patient, would you go with just PCSK9 monotherapy, or would you have ezetimibe and a PCSK9 inhibitor? Because people in their minds often just think about, well, it's 20% versus 50, 60%. But actually, when you start at 190, combination therapy is more likely to get you to 55 or less than 70, right?
Very well said. That's exactly what I would do. And I do it frequently for people who can't tolerate statins. I will often start the PCSK9 inhibitor first and then see where we end up. And remember that within about 5 days, you see the nadir for LDL. You don't have to wait a month, though most of us do. And then if the LDL is still above the threshold or not adequately lowered in my mind, I will add ezetimibe. So I think that's a really good point.
One of the things that comes up, Coach, is that she's had bad experiences with statins. So there still has to be a persuasion when you see this that, now I have an injection, and you talk them through this. And so this is one, Alan, where the COVID issue, I like to give that injection in the office so that it's someone shows them, and it's just reassuring, hey, it's easy, you've got we have samples, and frequently we give them a sample and do the first injection there. You can do that by video. You can do that. It's still, I still think it is a little more reassuring for someone who's been a lot of bad experiences, and they get the coaching, and they say, "Oh, that was easy." Because most people, I was dubious about injections when these trials started. But the patients do extremely well with it. But there is that psychological issue of that first injection, and a little bit of hand holding and coaching, I think, is helpful.
We do that now with a nurse so we get the approvals, bring the patient in, and it's with that nurse. So we show them with the dummy injectors. They self-inject in front of the nurse. Yes. I had a patient who had, God knows, so many side effects with statins, and just even the thought of having the injection. So she wanted to come back the second week. And I think the nurse did it the first time. She wanted to come back the second week, was in tears over the phone, brought her back. And you should have seen the smile on her face after she was able to self-inject. 2 weeks later, take that second injection. And, now you see her 6 months later for a refill. She's coming in, smiling from ear to ear. And it's just wonderful. That's the challenge, isn't it? I want to ask you both one really critical question. So, with all of these things, we talk about LDL reduction, combinations, etc. We don't talk about the speed of benefit and time. So, you highlighted, Alan, the ACS patient, and some of these people may come in because they've got diabetes and they've been on a statin, and maybe the decision's a little bit easier. But any thoughts about, because we have pathways, put them on statin first, measure the LDL, then do something else. And we know that many of these people get lost because that pathway gets extended, because a patient doesn't have symptoms. High or low cholesterol doesn't make you feel better or worse. So any thoughts about pathways, implementation, and that speed at which you want to achieve goal?
Yes, well, as you know, there have been some studies in Europe kind of testing the idea, at least with patients who had acute coronary syndrome, to give the PCSK9 inhibitor prior to discharge. And what they showed, there are two different studies, but one showed that just within a very short few days after discharge, the LDL was much lower than even those on high-dose statin. And these are proof of concept, basically. The other study showed that within 3 days of admission, even while the patient was still in, the LDL dropped.
One aspect is early benefit, which you're absolutely right. And then the other aspect is, we know that when things are often started in hospital, they're more likely to be continued. So if, for example, the patient had diabetes or a risk factor, or maybe an MI in the past, which might have been an easier case, and came in, they're on moderate high intensity statin or even high intensity statin, and the LDL is 100, we can do lifestyle and everything else all you like, but that residual risk is really high. for those patients, should be starting them in hospital. What do you both think?
So, Coach, a couple things. But one thing about pathway, and this is one of our big problems that came up, Alan, out of the 2013 guidelines, was that somehow physicians misinterpreted. They actually said you should check an LDL, because the first thing you have to do is if your treatment was inadequate. The same thing with adherence. You have to measure LDL.
Right.
The LDL tells you if they've been not adhering to their medication or their lifestyle. It is so valuable, and unfortunately, it got dropped off as a performance standard. So it used to be
due to, as you said, a misinterpretation of the guidelines, because it's in the 2013 guidelines, as Neil Stone will aggressively
it's in there.
say.
No, it's in there.
But someone didn't read it.
But it's still not in our performance standard. So any pathway should absolutely make sure that you include in this an LDL measurement. And Alan, I was on one of these think tanks, and we have a letter now trying to the performance standards people, please make it a performance standard again. If someone's had an ACS in the follow-up, you've got to check an LDL. So, and I think that, a lot our interventional guys typically see them at 2 weeks. So I said, look, just to make it easy with insurance, stick them on, make sure they're on a high-intensity statin, ezetimibe. If 2 weeks later their LDL's elevated, just hit them right then with a PCSK9. Because, like you said, if it's 85 or 90 and, 2 weeks after you've done that, it's going to stay up there. You've done it. You've got all the hoops for insurance. But I think we need pathways. First thing we got to do, though, is we have to measure LDL. And it's a shame that we looked at this Gould registry, Alan, and, it's not measured a lot. It just became statin, I'm finished. I put them on a statin, I'm done.
I couldn't agree with you more. I think that's almost criminal, that if you don't measure something, you can't make it better. And no one has ever, and in fact, even the guideline group from 2013 wrote a letter that should not be taken out of the performance measures. So, I agree with you, and I hope your letter will do something.
You're on. So, we're going to take some questions and answers now, and let's see what comes in. I have a question for Alan. Alan, plaque regression. So the underlying process is obviously atherosclerosis. What data do we have about plaque regression and PCSK9 inhibitors?
Well, we've got a couple pieces of data. We have the Glagov study that many of you are familiar with, where they used intravascular ultrasound to look at plaques in patients on statin alone versus statin plus evolocumab. And what you saw when you looked at the total plaque volume, keeping in mind that a large percentage of the atherosclerotic plaque is in the wall of the artery and may not be occluding the lumen, but the total plaque volume significantly improved in patients on PCSK9 inhibitors versus statin alone. And then there's one other really interesting, less known trial that was published in an Elsevier Journal of Cardiology last year from a group in Japan. And they used a different technique, what's called optical coherence tomography, to see how early you would see a change in the plaque morphology. So this is a technique where you shine from a light source through the tissues and look at the reflectance, and with a sort of a complex computer analysis, you can determine the morphology of the tissues. What they were able to show was very early on, when you compare patients who had a recent acute coronary event on a statin versus statin plus a PCSK9 inhibitor, that you saw a thicker fibrous cap on the plaque, which we all consider plaque stabilization, and we believe that correlates with reduced plaque rupture going forward. So early in the treatment, within just several weeks, the people who were on statin plus a PCSK9 inhibitor based on OCT evaluation seemed to have a thicker fibrous cap than those patients who were on statin alone. So that is not outcome data, but it's certainly encouraging that early therapy after acute coronary event will likely give us better outcomes. And so is the data regarding reduction in plaque volume.
Thanks, Alan. So I'm going to bring in Christy. So on that note, one of the questions we had So ACS patients, the highest risk, the trials didn't specifically address those. We know that some of these people need add-on treatment. Any numbers spring to mind about the use of PCSK9 inhibitors sort of early after post-ACS from some of the registry data that you were talking about?
It's still underutilized, Coach. If we take a look, the Swedish study actually began in the hospital. That's a European study, but was extremely infrequent. I think it's picking up. There's one of the problems in the United States is that the insurers of the hospital don't want to pay for the drug. So it's going to be usually started after someone leaves. At the current time, we'll see if certain healthcare systems where the system owns the pharmacy, the hospital, and the practices, but that's not the majority of the United States. That's the vast minority with it. So it usually gets started later. And as was started, the pathways have not been really well implemented for this. So I think it's one of the things we should be focusing on in cardiology is much more aggressive interventions post-ACS in regards to lipids.
Thank you. So, Alan, maybe, so one of the questions that comes to mind is there are some differences in different guidelines. So what, in your opinion, is the best LDL cholesterol for the very high-risk patient? And I know for the ASCVD criteria, as Christy showed, for example, we have those additional high-risk conditions as well. But do you think that it's 70 or lower?
I've said for 30 years, you can't be skinny enough, you can't be rich enough, and your LDL can't be low enough. And nobody's proven me wrong since I started saying that many, many years ago. And I think we have data from Fourier that the on-treatment LDL levels correlated well with the benefits. And the lower you got the LDL, the lower the risk of the patient. Keeping in mind that when LDL start getting really low, the prevalence of events is much lower. So even though the relative risk reduction goes down in a linear fashion, the number needed to treat goes up because the prevalence is lower. But with that said, I like 40. I think, getting LDL below 40 in an extremely high risk patient, and particularly a patient who is having recurrent events, as was recommended in the European guidelines, makes a lot of sense based on our observations.
Thank you. So I want to bring Christy back in and maybe to talk about, so this is really, it's an interesting question. I mean, they all have been, but this is regarding Lp(a). So we've seen a couple of analyses done from the outcome trials, and obviously these drugs low LDL, but they're low Lp(a) as well. And it was the suggestion, what's your view on using monoclonals in people with Lpa levels above 50 milligrams per deciliter, so 125 nanomoles, in people with established cardiovascular disease or calcific aortic valve disease? There's a suggestion from some of these analyses that you get a reduction in risk hazard ratio by about 1.5% per 1 milligram per deciliter, lowering, which kind of equates to 2.5 nanomoles. And obviously, these treatments are non-specific. Any thoughts, Christy, about that?
Coach, I'm fairly impressed with the data, and for two reasons. That it's as Alan points out, lower is better. So with the PCSK9 inhibitor, you're going to drop LDL down very frequently to very low levels, and we saw in Fourier, the lower the better. But basically, getting it, like Alan said, getting down to less than 40 appears to be the optimal zone, and you're also lowering Lpa. Now, it's not exceptionally good lowering, but still, it does appear that that's giving some additional benefit. So I consider that to be personally one of those factors that when we talk about very high risk patients, look at Lpa. This is my personal opinion. It's not the guidelines, but that should be another factor to influence considering the risk benefit of using one of these drugs. I think it adds to the benefit side.
So it influences your decision to initiate treatment, particularly as an enhancing factor. Okay, very, very good. Thank you. So a question back to Alan. I mean, you will have used, obviously, these drugs now. We've had them available for about 5 years, the MABs. Any issues with immune suppression? The question was specifically mentioning Repatha, but either Repatha or Praluent. And what's I mean, your experience been, and any data to suggest immune suppression as these are MABs?
Yeah, I don't know that there's any data to suggest immune suppression. I mean, what the concern is, if somebody has an autoimmune disorder, that actually giving an antibody can stimulate the immune response, in the sense that we see that many patients will develop antibodies against the drug, even though it is extremely rare that those antibodies actually neutralize the effect of the drug. So there's been this sort of theoretical fear that possibly giving the drugs to somebody who has some immune disorder might be a problem. There's no data that I'm aware of that shows that it is. And just for an example, I have a patient with autoimmune statin-induced myopathy who had HMG-CR antibodies. And he also was a South Asian with established coronary disease and a very high LDL. So we couldn't give him statins, and we had this theoretical concern about what might happen if we gave him a PCSK9 inhibitor. And happily, he's done beautifully. His myopathy has not gotten any worse. It's gotten better. And of course, on immunosuppressive therapy, and he's also on a PCSK9 inhibitor and has his LDL controlled. So this is one of those questions that is in the realm of the twilight zone. We just don't know, but I'm unaware of any data that there is either significant clinical sequelae from activation of the immune response or anything that would suppress the immune response.
Thank you. Very clear answer. So this is really the final question before we conclude the webcast. So I'm going to come back to Christy. So Christy, we obviously statins are first line, and we think about add-on and combination therapy. So one of the questions that came out was, in terms of cardiovascular risk reduction with non-statins, and either alone or on top of in combination, is there really a difference, or is it just related to the reduction in LDL irrespective of means, for example? Can you just clarify for the questioner?
So the data that we have all fits in very well, Coach, with the CTT meta-analysis that is based upon the additional LDL cholesterol reduction. So that is usually, I think, an important part of your decision-making process. What's the risk? How much do you want to reduce the risk? How much LDL cholesterol reduction can you get?
Very, very clear. And we have at least one trial with ezetimibe monotherapy. That was a Japanese study, I think, that was done in older patients. So we do have some data. We don't have that necessarily for monotherapy, but as you say, it fits perfectly. So gentlemen, I want to thank you all for a really lively and stimulating discussion, your presentation. That concludes the webcast on behalf of my colleagues and PeerView Live. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/ZWU860. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. In support of improving patient care, this activity has been planned and implemented by the National Lipid Association and PVI, PeerView Institute for Medical Education. The National Lipid Association is jointly accredited by the Accreditation Council for Continuing Medical Education, ACCME, the Accreditation Council for Pharmacy Education, ACPE, and the American Nurses Credentialing Center, ANCC, to provide continuing education for the healthcare team.